Okay, so today we're going to go through the miscellaneous cases number 2. So you can try and answer inside the chat box. Okay, so this is our first case. Right, so case number 1. So this is a parasternal long axis view. Okay, LV, LA, iota. So parasternal long axis view. Okay. Okay, this is short axis AOPA view. Play again. Short axis AOPA view. So that's aortic valve at the middle. Alright. And this is parasternal long axis. So parasternal long axis. Okay, so is it clear? So anyone want to say what is the diagnosis?
Again.
Okay, this is parasternal long axis view. So LV.
All right. Can you play the color?
LA, iota, right ventricle.
Yeah.
Okay, this is parasternal short axis view. So iota. Okay, LA. So this is short axis view at the AOPA level. Happy?
PDA.
Okay, I'll show you one more. Okay, this is class 1. Okay, parasternal long axis view. LV. Okay, I'll show you this one. Okay. Emery and ceiling.
Like you have an RVH and there's a flow in the aorta.
Very good. So what is this? What is this blue color here? This blue thing.
It's flow from the
Away.
Flow from where to where?
RV.
RV to iota.
Okay, RV to maybe iota, right? So if let's say you have a flow from RV to here, so what is it that allow the flow?
Shunt reversal.
So there is a shunt reversal. So what kind of shunt?
Looks like a VSD.
Very good. That is a VST. Okay, number 1. Okay. Now look at the iota. So this is the iota from here to here. What is the iota doing? So this is iota, right? From here to here.
Yeah.
This is the ventricular septum. So what is happening? So what is iota doing? There is overriding of the iota, right?
Oh,
Right? There's
that's
overriding of the iota. Okay, that's overriding of the iota. Okay. So this is the ventricular septal defect there.
POF.
Yes, this is tetralogy of fallot. So I just wanted to show you tetralogy of fallot. You can see that the right ventricular outflow tract, there is the right ventricular hypertrophy there. So right ventricular hypertrophy, you can see right ventricular hypertrophy there. Okay. So what else can you see apart from the right ventricular hypertrophy? What about this space here, this part here? Let's go back here. Right, let's go there.
Oh, that's why you have color because it has like pulmonary stenosis or something.
You use like that one. Wait, guys. Okay, wait, just give me a moment. Can you see the slideshow of miscellaneous cases number 2?
Yes.
Yeah.
Okay, right. So this is the one. So that's the next one. Okay, what can you see here? So you can see that the right ventricular outflow tract, right? It is actually stenosis. So there is pulmonary stenosis, and also there is pulmonary stenosis, and at the same time got pulmonary regurgitation. So you have overriding of the aorta, we have right ventricular hypertrophy, and you have also anterior malalignment of corner septum. So one of the reasons the patient have right ventricular outflow tract obstruction is the corner septum is actually displaced anteriorly. So this is your short axis view. So it's displaced anteriorly, so it causes right ventricular outflow tract obstruction. So look at this one. Okay, so where is the flow going? From the right ventricle to the left ventricle, or from the left ventricle to the right ventricle?
From the right to the left.
How do you know it's from the right to the left?
Blue color.
The
Okay,
color?
okay, color. Tell me what about the color that tell you that it is right to the left but not left to the right?
Away from the right.
So how do you know that it's away from the right?
Away from the probe because it's color blue.
Okay, because it's color blue, so it's away from the probe. Okay, so that is the reason. So this is right to left. Okay, I wanted to ask you all, if let's say this is a patient that is newborn, okay, and the flow is right to left, is this Eisenmenger syndrome or not?
Newborn.
No,
Why is it not
No.
Eisenmenger syndrome? Celine?
because it's newborn.
Okay,
Hasn't got time to develop Eisenmenger.
okay, so the right to left flow and the cyanosis, you don't think it is Eisenmenger syndrome? Okay, what is the reason patient with tetralogy of fellow, when they are newborn, the flow is right to left rather than left to right, you think? Why some baby, right, with tetralogy of fellow, when they are born, the flow is right to left rather than the other way around, left to right?
Right to left.
Anyone want to think about? Okay, so I just wanted to tell you, so Eisenmenger syndrome is basically, okay, the definition of Eisenmenger syndrome is development of right to left shunting, okay, because of increase in pulmonary vascular resistance. So you have to develop increase in pulmonary vascular resistance, pulmonary hypertension, then right to left shunting. Okay, so it takes time to develop. So for example, you have ASD. So the ASD is actually long-standing. So long-standing ASD cause increase in pulmonary vascular resistance and then cause right to left shunting. So that is Eisenmenger syndrome. Now, in patient with tetralogy of fellow, what is the reason they are having right to left shunting? So, do you familiar with the term blue tag, pink tag, ceiling? Ceiling?
Yeah.
So, blue tag is someone that is born and then they are blue when they have tetralogy of fellow. Pink tag is someone that is pink, meaning they are normal when they are born when with tetralogy of fellow. You know why someone has pink tag and someone has blue tag?
The relation with the pulmonary stenosis or the
Very
aortic
good.
outflow.
Very good, excellent. So what happened is that it all depends on the right ventricular outflow tract obstruction. Okay, so if the right ventricular outflow tract obstruction is very bad, so blood cannot flow through the pulmonary artery into the lung. So the only way that blood can flow is from right to left through the shunt. So not because there is an increase in pulmonary vascular resistance or pulmonary hypertension, but because there is right ventricular outflow tract obstruction. Okay, as opposed to someone that is, this is very rare, someone that don't have right ventricular outflow tract obstruction and then they actually have left to right shunting. So this patient does not become blue at birth. So this is what we call a pink tag. Okay. Sometimes people with tetralogy of fellow, they are cyanous. So sometimes what they do is they will go and squat. So they do a squatting and they will cry. And because they will cry, what happens is that they will increase their systemic resistance, the afterload. So because they increase the afterload, so the blood cannot go through the aorta and the shunt is reversed from left to right. So that's why people that have tetralogy of fellow, baby or young children, sometimes when they are becoming blue, right? So what they do is they squat or they cry to just increase their afterload to make sure that the blood goes down from left to right. So is it clear or not in terms of the tetralogy of fellow, the difference between pink and blue?
Clear.
Yeah.
Yeah. All right. Good. So Sarah, you okay? Did you get the discussion?
Just joined.
Okay, so basically what we're talking about is that this is patient with tetralogy of fellow. So this patient have right to left shunting. Okay. So I just tell them that not all right to left shunting is Eisenmenger syndrome. Because Eisenmenger syndrome, the definition is the development of right to left shunting after someone has developed increase in pulmonary vascular resistance and pulmonary hypertension, causing the reversal of shunt from right to left. So in patients, for example, with tetralogy of fellow, they are just born. They don't have time for the pulmonary vascular resistance to go up. So what are the reasons that some of them have right to left shunting through the VSD like this patient here? So the reason is because they have right ventricular outflow tract obstruction. So because they have the right ventricular outflow tract obstruction, the blood flow rather than go to pulmonary artery, they go from right ventricle to left ventricle. Not because of increase in PVR, but because of right ventricular outflow tract obstruction. So that's why in a patient that have tetralogy of fellow, depending on the degree of the right ventricular outflow tract obstruction, this determine whether they are blue tag. So blue tetralogy of fellow is patient with right to left shunting, meaning they have significant right ventricular outflow tract obstruction, or patient that has a pink tag. The pink tetralogy of fellow is the one that is not sinus. So this is the kind of patient that have left to right shunt because they have don't have significant right ventricular outflow tract obstruction. Is that clear?
Yep.
Okay. So sometimes during some people that have children, they have cyanosis, right? And then when they develop cyanosis, what they do is they will cry and they will spot. The reason they do this is they wanted to increase the afterload so that the left ventricular have increased resistance to go to the aorta. Now they go from to the VSD from left to right. So this actually caused the patient to revert from blue to pink by crying and spotting down. Is that clear?
Yes.
Okay.
So can I ask, so the
Yes.
right to left is through the VSD, is it?
Yes, to the VSD. Right? Okay, so that is tetralogy of fellow. So I just give you a salient point on tetralogy of fellow. So what is the main abnormality in tetralogy of fellow? It is the anterior deviation of the corneal septum. So the corneal septum, so there is only one abnormality actually, and one abnormality that caused the problem. So that caused the other problem with tetralogy of fellow. So like an example for the picture here. Okay, so this is actually the corneal septum there. Okay, that is the corneal septum. This the top one, not the bottom one. The top one is the corneal septum. So that is your anterior. So this is actually deviated anteriorly. So because it's deviated anteriorly, so you have the ventricular septal defect. Okay, and if you look there, oh, don't worry about it. Luckily, we just first. So if you look here, all of you can see the skin, right?
Yeah.
Okay.
Yeah.
So if you look here, so this is the short axis view here. So this is short axis view. So because of the anterior deviation of the corneal septum there, so that is the right ventricular outflow tract. So therefore, you develop right ventricular outflow tract obstruction. So you have anterior deviation of the canal septum. So the corneal septum deviated from here to here, crowd the right ventricular outflow tract, cause right ventricular outflow tract obstruction, and also cause right ventricular hypertrophy. Okay, so this is actually the reason the patient with tetralogy of fellow have all their abnormalities. Is that clear?
Yeah.
So this causes the overriding of the aorta and right ventricular outflow tract obstruction. So whenever you assess a patient with tetralogy of fellow, their obstruction can be anywhere along the length of right ventricular outflow tract. So it can be the infundibulum. So what is the infundibulum? The infundibulum is just below the valve. Okay. It can also be below the infundibulum. So for example, someone that have double outlet right ventricle, or it can be valvular, it can be supravalvular, it can also can be branch pulmonary artery stenosis. So just not one part. One of the places that we wanted to look is someone that have blood toxic shunt. So Precious, what is blood toxic shunt?
BTS.
Hmm.
Going from the FVC to the PA.
No, that is spontan. So the reason we have blood toxic shunt is to give patient pulmonary circulation. So a lot of patients with congenital heart disease, they don't have pulmonary blood flow, pulmonary supply to pulmonary, because we need supply to the pulmonary to get oxygenated blood to the rest of the body. So one of the way to do that is by using blood toxic shunt. Okay, so Saravanan, blood toxic shunt.
Forgot.
It's from some subclavian to pulmonary artery. Is it?
Very
Yeah.
which subclavian? Right or
Right
left?
side, right.
Very good. Okay, that's actually they use a vortex from the right subclavian to the right pulmonary artery. Okay, what they do is they try to reinvent a PDA. So the last time, this cardiologist by the name of Helen Tosick noted a patient that is born with congenital heart disease that is cyanotic. Those that have PDA perform better, patent ductus arteriosus. PDA is the connection from the descending aorta to the pulmonary artery. So she postulated that now if you have PDA, can we mimic PDA or not? So what happened is she had an idea. So why don't we connect the right subclavian artery to the pulmonary artery? This will just mimic PDA. So this is the blood toxic shunt. Is that clear?
Yeah, clear.
There is also other shunt, but the principle is the same. It is a connection from the aorta to the pulmonary artery. So we have other things like we have Waterstone shunt. So Waterstone shunt is the connection from the ascending aorta to the pulmonary artery. We have Port shunt. Port shunt is the connection from the descending aorta to the pulmonary artery. So the name is not important. The important thing is the principle behind it. So some of the patients that have blood toxic shunt, at the insertion of that shunt at the right pulmonary artery can also develop stenosis when they are old. So that is one of the important things to check when patients have blood toxic shunt when they become old. Is that clear?
Yeah.
Okay. So in rare cases, the patient can have double chambered right ventricle due to anomalous muscle bundle. So what happens is that the patient in the middle of the right ventricle outflow tract, they can have another anomalous muscle bundle in patient with tetralogy of Fallot. So this also can happen. So now you have like two chambers inside the heart. You have proximal chamber and the distal chamber that is separated by this anomalous muscle bundle. It can be anomalous muscle bundle, or it can be right ventricle that has been hypertrophy abnormally. So you can have double chambered right ventricle. So the first total correction of tetralogy of Fallot, meaning that they correct not by making shunt, but proper correction, meaning that they close the VSD and put the class annular patch is done by Dr. Walton Lillehei in the University of Minnesota, I think in 1950s. So what happened in this patient is they use the patient parent as their bypass, as their oxygenated, because they need to operate on the heart that is stopped. At the time, bypass machine hasn't been created yet. So what they do is they use the parent as the bypass machine. So they actually reroute the baby in the blood to the parent. So the parent is the one that become the pump and also become the oxygenator. So at that time, how do they correct tetralogy of Fallot? So a lot of people think that the pulmonary valve is not important in humans. So when they do earlier surgery, what they do is they just take out the valve and they put a transannular patch. So the patient will no longer have pulmonary valve. The problem with this approach is that this causes free flow pulmonary regurgitation. So this causes, when the patient is 30s or 40s, they develop right ventricular dilatation. And this right ventricular dilatation later will become right ventricular failure. So this is not good for the patient. So now we know that the surgery that is done now, they look at the pulmonary valve, then they just trying to decide whether the pulmonary valve is big enough for them to preserve the pulmonary valve, meaning that they will resect the muscle below the pulmonary valve, they will resect the muscle above the pulmonary valve, and they will maybe correct a little bit of the pulmonary valve, but then left the pulmonary valve there because they do not want this pulmonary regurgitation to happen. But the problem with this approach is, of course, that pulmonary valve can cause pulmonary valve stenosis. So they have to balance this kind of thing. Okay. So if let's say nowadays, let's say you now work and you see a lot of patients at their 30s or 40s that develop free flow pulmonary regurgitation. So what we need to see is how dilated is the RV so that we can decide whether to offer pulmonary valve replacement. So there is a threshold of how big is the right ventricle is. So we use MRIs. So if the right ventricular end diastolic volume index is more than 150 mils per meter squared, or right ventricular end systolic volume index is more than 90 mils per meter squared, and then that is an indication for us to do pulmonary valve replacement. Depending on the size of the transannular patch, if the transannular patch is big, they cannot do transcatheter and put a melody valve inside. So they have to do a pulmonary valve replacement, and usually they put a bioprosthetic pulmonary valve. If the transannular patch is small, they can actually do a transcatheter and put a melody valve in. So some people, the first time they put a bioprosthetic valve, but the second one they do valve in valve. So they can put a sapien valve inside that bioprosthetic valve. So what is the long-term complication from TOF repair? Of course, we have that free flow PR from the transannular patch. Now, the main problem and one of the biggest problems is sudden death. So we don't really know what we can do for this. Okay, in patient with aborted sudden death, we can put ICD. But what is the indication that the patient have high risk of sudden death? So one of the indications is very big right ventricle. And also someone that have older type of surgical approach. Patient with TOF also, as you can see, they have very commonly dilated aorta. However, dissection surprisingly is extremely rare in the tetralogy of fellow cohort. Okay, so just wanted to tell you in terms of surgical approach of tetralogy of fellow after this. Okay, so let's go to our second cases. So this is a parasternal long axis view. Okay, so LA, LV, aorta, right ventricle. Okay, right. This is the short axis view. Right, short axis view. Okay, I play again. Short axis view. Okay, clear? Right. So what is your differential diagnosis? Saravanan, feeling, precious?
Subaortic
Subaortic what?
VSD.
All right. So this is a ventricular septal defect. Okay. So look at this. So what type of ventricular septal defect?
Need to look at the short axis.
Okay. So just looking at here, what is your differential diagnosis in terms of the different type of ventricular septal defect?
Can be inlet or outlet. I mean, membranous or outlet.
So it can be either perimembranous or outlet VSD. Okay? Either premembranous or outlet VSD. So this is the short axis view. Okay. So what kind of VSD is this?
Subaortic outlet.
Outlet.
So this is example of outlet VSD because the shunt is actually nearer to the pulmonary valve. So outlet VSD. So what is the complication that you can have from outlet VSD? So one of the complications is the right coronary cuts, as you can see, is just at the side of the outlet VSD. So that right coronary cut can actually prolapse inside the outlet VSD and cause aortic regurgitation. So this is actually the outlet VSD. So looking at the Doppler across the ventricular septal defect, so what do you think? Is this VSD big or small?
It's 6 meters per second.
So 6 meters per second is big or small?
It's big.
Okay.
Anything more than 4 is big.
Okay. Saravanan?
Small, right? I think small, right? That's
Yeah.
why the pressure is high.
Yes. So actually it is small. Actually. That's why the pressure is high. So the bigger the pressure, the more the pressure between the left ventricle and right ventricle equilibrate, the bigger the hole. So the smaller the hole, the bigger the difference in pressure. So anything that is more than 4 meters per second, we call it restrictive ventricular septal defect. Okay.
Okay.
So this is outlet VSD, restrictive outlet VSD. Okay. So high velocity across VSD more than 4, that is usually a small VSD. Right. So this is another case. So this is a short axis view. Okay, that is short axis view. Okay, one more time. Okay, short axis view. Okay. So this is the flow at the short axis view. Okay. So what is your diagnosis?
Perimembranous.
So this is example of perimembranous VSD. as you can see, the shunt is beside the tricuspid valve. Okay? So this is a perimembranous VSD. So for perimembranous VSD, because the hole is actually beside the tricuspid valve, so what happens is, one of the complications is the septal leaflet of the tricuspid valve can actually prolapse into the hole. Okay, it can close the hole, but the problem is that can cause tricuspid regurgitation. So now, Celine, look at this Doppler. Is it a big VSD or small VSD?
It's 2 meters per second. So velocity it's low, so it's a big VSD.
Okay. So Celine, give me 4 types of ventricular septal leaflet.
Muscular, perimembranous,
Yep.
inlet, outlet.
Very good. All right. Okay, this is a perimembranous VSD, and we have low velocity, so this is quite a big VSD. Okay, just wanted to tell you the flow across VSD is mainly during systole, but there's also some during diastolic flow. Okay, it's not like zero diastolic flow. So this is the salient point on ventricular septal defect. So significant VSD will usually cause flow that is less than 4 meters per second across the defect. The size of VSD, so one of the way is the velocity, another way is just to compare the size of VSD with the aortic annulus. If the size of VSD is less than 25% the size of annulus, it is small. If it is between 25 and 50%, it is moderate, and if it's more than 50%, it is severe. If you compare to VSD and PDA to ASD, so VSD and PDA cause more pulmonary hypertension. Because if you think about it, the reason is, if you have VSD, because the flow from the left ventricle to the right ventricle occur in systole, so the blood straight away go through pulmonary artery, as opposed to ASD, where it flow into the right atrium during both systole and diastole. So VSD and PDA actually cause more pulmonary hypertension. And because the flow bypass the right ventricle and go to the pulmonary artery and go to the left ventricle, both VSD and PDA at first will develop left heart dilatation as opposed to ASD. But you have to differentiate this chronic VSD that is congenital to the VSD due to rupture post-myocardial infarction. This situation is different. This situation because the right ventricular have not enough time to adapt. What happens is the pressure on the right ventricle actually go higher than the left ventricle, and you have right ventricular dilatation. So right ventricular dilatation in acute VSD, left ventricular dilatation in chronic VSD. So this is our next example. Okay, so look at this. This is a short axis view. So this is a short axis view, right? So that is the aorta there. So that is the short axis view. Okay, and that is the color flow across the short axis view. Okay, that's the color flow across the short axis view. All right. So diagnosis, pressure.
Perimembranous VSD.
Nope. Saravan?
Mine is very laggy. I cannot see.
Okay, I just play for you. Continue playing for you. Continue playing for you. So this is a flow across the right ventricular outflow tract. Okay. So that is the aortic valve. That is the pulmonary valve. This is the flow across the right ventricular outflow tract. Okay. So what do you see here?
That is defect, right?
Okay. So what do you see here in terms of the flow? So this is the flow across the right ventricular outflow tract, and you see something there. What is that?
Oh, it's a
What happened to the flow through the right ventricular outflow tract?
Oh,
It become what?
some
Narrowed there.
Okay, so it becomes turbulent, right? The flow?
Turbulence, yeah.
Yeah, it becomes turbulent, right? In the middle of the right ventricular outflow tract. If you go to the previous gambar, okay, so this is the right ventricular outflow tract. So there's something there that caused the turbulent flow across the right ventricular outflow tract. So you have one chamber distally and one chamber proximally, okay, and you have muscle in the middle. So what is this?
Subfundibular.
Okay, so this is remember the one I told you before in patient with tetralogy or failure, or even someone with ASD, sometimes they can have either abnormal right ventricular hypertrophy or anomalous muscle bundle. if they actually big enough to cause obstruction, so you have one chamber distally and one chamber proximally. So what is your analysis?
So
Double.
the outlet, right ventricle.
One chamber, I already do the clue. One chamber proximally and one chamber distally.
Double chamber, right ventricle.
So this is double chambered right ventricle. Okay, you can see that. You can see the flow turbulent at the middle there. So proximal chamber, higher pressure, distal chamber, lower pressure. So you have turbulent there across the right ventricular outflow tract. So this is proximal and distal chamber. So this is the example of double chambered right ventricle. Is that clear?
So is this TOF then?
No, this is not TOF. This is someone we don't know what's the reason, but sometimes you can have congenital anomalous muscle bundle, and sometimes it can be because of ventricular septal defect. What happens is your VSD flow actually go towards the right ventricular upper tract, so this cause response hypertrophy there, and you can have double chambered right ventricle. Is that clear?
Yeah.
Okay, everyone?
But there is VSD as well, right?
No, there is no VSD in this situation.
There's no VSD, okay. It's just turbulence lah.
Yeah, just turbulence, correct. Is that clear in terms of double chambered right ventricle?
Yes.
Right.
All right. Okay. So, Sarah, dialysis.
Yeah.
Okay, this is the Wait first. I give you the other gambar first. So this is the parasternal long axis view. Okay. So this is left atrium, left ventricle, right ventricle. Okay. I hope you can see the pink plane.
Yeah.
All right. So we go to short axis view. So this is the short axis view. Okay. Now, Saravanan, what is your diagnosis?
Is it a muscular VSD?
Very good. So this is an example of muscular VSD. Okay. So what is the commonest VSD in childhood?
Muscular.
How come in adulthood it becomes very membranous VSD?
Because in muscular they will close in childhood, right?
Yes, they actually will close spontaneously. Perimembranous also, some of them will close spontaneously, but the one that is most common is muscular VSD. Correct, this is muscular VSD. Okay. What about the size of the muscular VSD, Sarah?
The size is on the dot.
Yeah, on the dot, huh?
It's restrictive. Eh?
So just borderline. Okay, so a bit difficult. So we might want to find some other way to see what is the VSD. I wanted to advise you, don't rely on QPQS from echo. QPQS from echo is very, very unreliable. QPQS from MRI is okay. From echo, don't rely on that. So whenever you assess shunt, my advice to you is just look at other things rather than the QPQS. So this is actually muscular VSD with borderline something. Okay. So this actually now is a question on diastology. Okay. So this is someone with 76-year-old patient. Ejection fraction is normal. There is no left ventricular hypertrophy. So what is your diastology for this patient? Okay. Grade 1, grade 2, grade 3, grade 4, normal.
Trying to get a different place.
Okay. Yeah. Okay. It's not important to see the movement. Just realize that the patient EF is normal. The left ventricular function is normal. Okay. So you can see that the E over E prime is less than 14, but the E prime is less than 7, which is 6 capital E prime. The left atrial volume index is normal, and tricuspid evacuation velocity is less than 2.8. So is this a normal diastology? Grade 1, grade 2, or grade 3?
Grade 1.
Okay, so Saravanan say grade 1. Ceiling?
Wait, let me recall. Only fulfill one. I would say it's normal.
Okay. So what about you, Precious? Normal, grade 1, or grade 2, grade 3, grade 4?
Can still be normal because the lobby is still normal.
Yeah.
Right. So Saravanan, why do you say that this is grade 1 diastolic function?
Because the E prime is 6.
Okay. So in this situation, right, you know how many algorithms that we use for assessing diastology?
Two.
Okay, so you want to use algorithm 1 or you want to use algorithm 2?
This one we can use algorithm 2, right? Because the septum looks a bit thick. Am I right?
Look at my stem there. There is no left ventricular
Oh,
hypertrophy.
right. Okay.
So
Then there is no diastolic dysfunction.
okay, so it is normal. So anyone want to change the answer? So it's correct. Okay, so this is all of you are correct. So this is actually a normal diastology. So I just tell you only the EF is normal. There is no left ventricular hypertrophy. So you need to use the algorithm 1 first. So the trick in this question is that the E over A is less than 0.8. Okay. So you might think that this is grade 1 diastolic dysfunction, but remember I told you if everything look normal, always use the algorithm 1 first before deciding whether the patient have diastolic dysfunction or not. Just looking at algorithm 1, only one character that is abnormal, so this patient have normal diastolic function. So this is just because of aging, right? Right. Let's look at this one. So this is another patient, 71 years old patient. Okay, tricuspid irritation velocity is 2.6. Left atrial volume index is 39 mils per meter squared. Okay, so what is your answer? Normal, grade 1, grade 2, grade 3.
Grade 1.
Okay, Saravana?
Order.
Again, here is normal, right?
Yes.
Lavi is
Yeah.
enlarged.
So you want to use algorithm 1 first or algorithm 2?
1.
Okay, you want to use algorithm
Oh.
1 first. So out of algorithm 1, how many is positive?
I think it's normal.
Yeah, very good.
Normal.
So 3 is normal, 1 is abnormal. So this is the again someone with a normal diastology. Okay.
Yeah.
All right. So what about this patient? Okay. So this patient, what is their diastolic function? So I don't want to give you anything else. So up to you if you want to use algorithm 1 first or algorithm 2. So decide which is appropriate. Okay. So normal, grade 1, grade 2, grade 3.
Confused.
Grade 3.
Okay. So what is the reason grade 3 diastolic dysfunction? Ceiling.
EA more than EA is so high.
Okay.
And then,
EA is so high.
and then it fulfills 3.
Very good. Okay. So what happened in this patient is, okay, even if you start with algorithm number 1, it actually fulfills 3. So if you go to algorithm number 2, then straight away you know that E over A is more, way more than 2, which is 6. So this is actually the A, okay? That's the A there. Not this one. This one is just the artifact. So that's the A there. Okay, what else can you see here on the E, on the mitral inflow?
AF. No A.
Yep. So what is this?
Fuse.
Okay, that is the L wave there. Okay, this is the A. So you can see the L wave. Okay, the L wave on the top there. So this is one. Pressure, are you still there?
Yeah.
Okay. So this is grade 3 diastolic dysfunction, restrictive diastolic dysfunction. Okay. The EA is more than 2 and there is even L wave. So don't even need LAVI in this situation. All right. So just looking at this 3 echocardiogram, okay, which one have normal myocardial relaxation? But which one do you think have normal diastology? Okay. A, B, or C? Okay. Just by looking here.
Well, it's A.
All right, very good. Right, so everyone answered A. So very good. Because remember when we measure the E prime, we measure actually the longitudinal velocity, and you can see that is where the wall moves. That's where the wall moves, and you can actually see that the E1 is the one that is moved faster. Okay, so A is the one that is normal. Right. Okay.
It move. What do you mean? It move faster?
Move from here. You see the way it moved from here to here, the longitudinal movement. It moved. Okay, so it moved from here to here. So it's the fastest one. So meaning that it moved fast from here to here. You get me? The thing this one I just need to restart the program. The problem with this PowerPoint is because there's a lot of video. So let's go down. Right. So this is another case. All right. All right. So this is the apical four-chamber view. So left atrium, right atrium, left ventricle, right ventricle. Okay. So left atrium, right atrium, left ventricle, right ventricle. Okay. Right.
Yeah.
Okay. So what is your diagnosis?
Peudoaneurysm.
This is a left ventricular pseudoaneurysm. Okay. So what differentiates left ventricular pseudoaneurysm and aneurysm? So what is the difference between pseudoaneurysm and aneurysm, Celine?
One has a neck.
Both have a neck.
One has a narrow neck.
Okay, which one have a narrow neck?
Pseudo.
Okay, the aneurysm got a big neck. So, Precious, if you want to talk about what is the pathophysiological difference between pseudoaneurysm and aneurysm? Precious?
Muscle continuity.
So loss of the continuity. Okay, what if they say someone asks you, right, what actually happened that differentiates pseudoaneurysm and aneurysm?
So in pseudoaneurysm, you only have the thin layer of what, the epicardium.
Okay, Sarah, almost correct.
Lupa dah. Forgotten.
Celine?
Pass. I don't know.
Okay, so what happened is that in aneurysm, okay, there is a preservation of all layers of the wall. So all layers of the wall is still there. So your endocardium, your big myocardium, and your epicardium is still there. Okay, so that is aneurysm. In pseudoaneurysm is that the integrity of the layer is there's no more. So either the whole layer is disrupted or part of the layer is disrupted, but you don't have the integrity. For example, in this patient, so this is the heart myocardium, but this the rupture of the whole of the myocardium. So this wall here is consists of the pericardium or clot. So there is no myocardial wall here. So that's the difference between aneurysm and aneurysm.
So that means it is the clot is within pericardium lah.
Yes, it's within the pericardium, correct.
Oh.
Okay, so what about this one, Saravan?
This one is also
Okay.
pseudo, right?
So this is
Pseudoaneurysm.
also a pseudoaneurysm. Now, you can notice here, the apical wall is actually separated to two layers. So the wall layer is no longer intact. So you have a pseudoaneurysm there. So that's another pseudoaneurysm. Very good. So, so we have here 52 years old man with NYHA class 3 to 4 awaiting for heart transplantation. So the patient had echo, CAT, and MRI. So you just took over his care in heart failure service. So this is part of the Doppler that you see.
Can I sorry? Can I ask one question about the pseudoaneurysm just now?
Yeah.
If you have pseudoaneurysm and then the connection is connecting to the pericardium, right? Eventually they go into tamponade lah, is it?
If let's say it actually the clot goes off, if let's say the pericardium and the clot it doesn't go off, for example, the clot actually enclose the cavity, so then it will stay like that. For example, the clot actually rupture and actually the blood can flow and surround the heart, then you can develop tamponade.
Oh. So that means the clot is separating into a few sort of chambers in pericardium, sir.
Very good. Yes.
But the flow is one way, right? It's not like a two-way blood flow in the
flow in the cavity is to and fro. So the blood go into the cavity, going back into the heart. Into the cavity, going back to the heart. That is one of the another characteristic of pseudoaneurysm. So this doesn't happen in aneurysm.
All right. Okay, thanks.
So again, this is a 52 years old man waiting for heart transplantation. So you just stop over his care in heart failure service. So what would you do for this patient and tell me why? Okay. Are you going to do pericardiectomy? Are you going to do transplantation? Are you going to do myocardial biopsy? Are you going to do repeat cath? Are you going to give a long talk with previous staff and the surgeon? So remember, the patient is awaiting heart transplantation. Okay. So maybe we start with Cecily.
Wait, let me think first. Wait. The first picture is septal E prime, right?
Yes.
Do you have lateral E prime? Septal E prime is very high.
Very good.
I think this is paradoxical. What's that called? I
What
think
is
this
it called?
patient has got constrictive pericarditis.
Okay, very good. You think this patient has positive studies. Why?
Because there is the mitral inflow, there is more than, it looks like there is more than 25% respiratory change.
Where is the mitral inflow?
Is it mitral lah?
No.
The
So-
second one, no.
So explain the first one. Why the first one gives you diagnosis of constrictive pericarditis?
Because it's what is that called? Paradoxical.
What is it called?
Paradoxical.
I forgot already. Okay, Saravanan, what is it called?
The exaggerated medial.
So the middle ephraim is high, 16.
Yeah,
So that is
Yeah.
very high. If you have infiltrative or heart failure, you expect that to be low, right?
low.
So
Yeah.
what is that called? When you expect it to be high, low, but it is high.
Paradoxical septal.
Oh, annulus
Annulus
paradoxus.
paradoxical.
Annulus.
Okay.
Annulus paradoxus. What do you call when septal is higher than lateral?
Annulus paradoxus lah.
That's not the paradoxus is when it's higher than you expected.
Oh.
Okay,
And
but
this
when
is reverses.
Yes,
Reverses.
annulus reverses. So this is obviously not a heart failure because of the heart problem. So obviously the patient
Yeah.
shouldn't go for transplant. Okay, that is number one. What about the picture number two? This is a hepatic vein flow Doppler. So what is that tell you that this is constrictive pericarditis?
There is flow reversal.
So there is flow reversal. Okay, when is the flow reversal?
Where?
When during the respiratory cycle? I will read right there for you.
Expiration.
Yes, sir. So you can see that this is inspiration and this is expiration, and you can see that the diastolic reversal is higher on expiration. So this is one of the most specific signs of constrictive pericarditis when you have exaggerated diastolic reversal flow with expiration. This is very important. With expiration. Okay. So what are you going to do now? Pericardiectomy, transplantation, myocardial biopsy, lipid tap, or a long talk with previous heart incision.
Pericardiectomy.
Talk first lah. Talk first to the
Long talk first, then pericardiectomy.
talk first lah. The simply pericardiectomy. So, but actually the first, okay, let's see. Actually, whenever you see a constrictive pericarditis, right, what is your first step in terms of management? So let's say you diagnose constrictive pericarditis from echo, what do you want to do?
Okay.
This is actually the first patient you see. So remember that echo is a better diagnostic modality than CAP for this kind of thing. So in terms of management, what you want to do?
Pericardiectomy.
Okay, pericardiectomy, very good. But what do you want to do before pericardiectomy? What you wanted to do first is you wanted to see whether this is reversible or not. So very like a minority of patients with constrictive pericarditis, they are reversible. How do you know it's reversible? So what you do is you do a cardiac MRI. So you look at left gadolinium in cardiac MRI. So what you wanted to show is you want to see whether the left gadolinium is actually bright with pericardium. So left gadolinium is actually denoted to either it is a scar, which is a replacement fibrosis, or is it inflammation? So if it's in the pericardium and the pericardium is bright, most probably you have an active inflammation. So in this kind of cases, you try to give them your triple therapy first. Your NSAID and plus colchicine first and see. So some people with constrictive pericarditis will actually respond to this, and you don't need to do pericardiectomy. Okay. If they say you do LetGet and LetGet got very bright pericardium, give them anti-inflammatory first and see whether they respond. Okay. If not, only you do pericardiectomy. Is that clear?
Yeah.
Okay, good.
Let's get very bright the whole pericardium.
Pericardium, yes.
Just
The whole pericardium, yeah.
whole pericardium.
Yeah.
Like in viability, they have like 17 segment, things like that. This one, is there like a segment for pericardium?
So there's no segment. Pericardium is just one layer there.
One layer, so
Yeah.
the whole thing lah.
The whole thing is bright. I mean, probably loading 100%. If let's say you see circumferential, like most of it is bright and it's considered bright. Okay, and then you can start anti-inflammatory therapy. Right? All right. So this is constrictive pericarditis. Very good. Okay. So do you remember when I give you a talk about the difference between pericardial tamponade and effusive constrictive pericarditis? Now we see whether pressure can tell pressures. So you see a patient, right? So this patient is having pericardial tamponade now, right? And you look at the echo, right? How do you differentiate someone that have echo with pericardial tamponade, which when you do tapping and then will become better, or someone with effusive constrictive pericarditis, i.e., this patient when you do tapping, the right atrial pressure will still be high. So how do you differentiate between the two? So both these patients have pericardial tamponade. One will become better when you do tapping, and one will become constrictive pericarditis. How you differentiate between the two pressures?
Respirometric studies.
Okay. What's the difference in terms of respirometric studies between the effusive and pericardial tamponade?
Well, for effusive, you'll have just like the constrictive,
Okay.
you'll have the reversal of flow.
Okay. So what you have is we have expiratory reversal of diastolic flow in hepatic veins. Okay. Some more.
The 25% increase in. Yeah, I forgot.
So basically, in patient with pericardial tamponade and effusive constrictive pericarditis, both you can see exaggerated respiratory variation across the mitral valve flow. So both you can see. Okay. So maybe Saravanan, you wanted to try and help?
No, I tak ingat.
Okay. Celine?
In constrictive pericarditis, you will see annulus reverses and annulus paradoxus.
So one of the most important clue is look at the E prime. So usually in a normal pericardial tamponade, the E prime will be low, but patient that will develop constrictive pericarditis, i.e. effusive constrictive pericarditis, the E prime will be high. Sama?
Both will develop septal bounce, right?
Okay, not necessarily. So what happens is that because in tamponade, the water, the restraint is not as strong as someone with constrictive pericarditis, even though both will have respiratory variation, but you expect to see more septal shift in respiration with effusive constrictive pericarditis. So basically, the differential between the two is basically you are correct. So both have some amount of respiratory variation, but in effusive constrictive pericarditis, you have more restraint. So you have more interventricular dependence. So how you want to differentiate? Obviously, because both present with tamponade in this case, so you can see diastolic RV collapse. However, when we look at effusive constrictive pericarditis, we can see echo similar to constrictive pericarditis even before tapping. So one of the clue is in tamponade, the E over A is less than 1 normally, and effusive constrictive pericarditis, E over A is more than 1. Number two, the E prime, just like you said, is normal or high in effusive constrictive pericarditis, but low in tamponade. Number three, because the restriction, meaning that the pericardial restraint is more in effusive constrictive pericarditis, you see the septal shift more commonly seen in effusive constrictive pericarditis, but less so in tamponade. So in summary, you see the consequence of exaggerated interventricular dependence much more common in effusive constrictive pericarditis. Okay. In tamponade, however, the pericardial restraint is less, therefore no exaggerated interventricular dependence. Right? Do you understand what Saravanan?
Yes.
Right. So basically, in pericardial tamponade, you don't have that increased restraint. So you don't have that increased interventricular dependence. That's number one. Number two, in tamponade, you don't have that high E prime, just like you have in effusive constrictive pericarditis. So now this is a patient. Okay, this is a 71-year-old man with dyspnea 2 years after bypass. So this patient have history of coronary artery bypass. So the patient have dyspnea. Okay. Now in physical examination, reveal that the GFP is elevated. There is prominent S3 and there is peripheral edema. Catheterization show equalization of end diastolic pressure. CT was obtained that show calcified pericardium. Okay. So what is your diagnosis, Precious?
Constrictive.
Precious?
Constrictive pericarditis.
So Precious says constrictive pericarditis. Saravanan, are you agree?
Oh, but
Yeah.
So Saravanan agree. What about you? Celine, agree? Constrictive pericarditis?
Agreed.
Okay. Now look at this left ventricle and right ventricular pressure. Okay, what do you think about the left ventricle and right ventricle pressure? So this patient have a concomitant catheter in the left ventricle and also in the right ventricle. So what do you think in terms of the movement of pressure in the left ventricle and right ventricle? Is it concordant or discordant?
Concordant.
So it is concordant, right? So it is so when LV is going down, RV also going down. When LV is going up, RV also going up. So this is constrictive type or restrictive type is like this. In constrictive, it is discordant or concordant?
Discordant.
So in constrictive, it is discordant, right? So this is concordant. So do you want to revise your answer? Is this constrictive or restrictive?
Restrictive.
What about you, Sarah?
Oh, sorry. If it is constrictive, it should be concordant lah.
It's constrictive, it should be discordant. So as the LV
Discordant.
pressure go up, RV go down. As RV go down, LV go up. But this is concordant. So are you still going to think constrictive or still going to think constrictive or you change to restrictive?
Restrictive, restrictive.
Okay, so now you all change that. At first you say constrictive, now you say restrictive. Okay, so are you okay with your answer now, or you want to do something else?
Do echo.
Okay, do echocardiogram. Very good. Okay, so let's do an echocardiogram and see. Okay, because so we do an echocardiogram. So the prominent S3, if you want to know what is S3, S3 is actually a rapid Y descent. Okay, what is Y descent? So A wave is atrial contraction. So C wave is the early systole. Then X wave is atrial, X descent is atrial realization. Then V wave is the late systole. And then Y descent is early diastole. So this is the flow from the left atrium to the left ventricle at early diastole. For this patient, the ventricle is so steep that, and the left atrium is so steep that you have rapid flow of blood from the left atrium to the left ventricle. Okay, this is the echo. All right. So the E prime is less than 5 centimeters per second. Okay. The E over A show a restrictive pattern with sharp deceleration time. Okay. So what do you think about this echo? Is it still consistent with constrictive pericarditis?
No.
No.
No. Why no?
The septal E prime is low.
Well,
Very
septal
low.
E prime is low. That is one of the most sensitive way for you to rule out constrictive pericarditis. Because septal E prime that is less than 5 is very, very abnormal. So this is not constrictive pericarditis. So this is a hepatic vein. Okay, you can see inspiration and expiration for the same patient. So what is your comment on this hepatic vein Doppler? Is it constrictive or restrictive?
There is a variation, right? The
No, there is
variation is supposed to happen during expiration.
Okay, so the reversal should, the exaggerated diastolic reversal should happen in expiration, but in this patient it happened in inspiration or expiration. Okay, the reversal is more in inspiration or expiration.
Inspiration.
So inspiration, so this is more consistent with restrictive or constrictive pericarditis.
Constrictive.
No, constrictive is expiration. Remember we talked about it? Constrictive is exaggerated diastolic reversal in expiration, and this is inspiration. Okay?
Inspiration.
Okay, so this is
Restrictive.
inspiratory diastolic flow reversal. This is restrictive cardiomyopathy. Okay, so what I wanted to show in this case is actually this. Okay, now the CAT and your CT scan alone is not sufficient to diagnose constrictive pericarditis. Okay, sometimes that can bring you to a wrong diagnosis. Always look at your echocardiogram. It doesn't necessarily patient have calcified pericardium, meaning they have constrictive pericarditis. Remember the thought that I gave you before? How many percent of patients that have calcified pericardium does not have constrictive pericarditis? If also the thickness of the pericardium, also not necessarily patient have constrictive pericarditis. Look at their echocardiogram. Okay, so what is our summary in this patient here? The patient have concordant changes in LV and RV with CAP. You know that this is not happen in constrictive pericarditis. In constrictive pericarditis, it will be discordant. Why it is discordant? Because you have that tight pericardium caused as a generated interventricular dependence. So when expiration, there will be flow towards the left side, but it will push the septum towards the right side. So there will be less flow towards the right side. So on expiration, the pressure go up on LV and go down on RV. On inspiration, the pressure go up on RV but go down on LV. So it will be disordered in constrictive pericarditis. Are you okay with the first one? Okay, now Sarah.
Boleh ulang tak? Sorry.
So in patient with constrictive pericarditis, because of they have pericardial restraint, so the heart cannot expand like this. So when the expiration, there is more flow on the left side. So the pressure go up on the left side. The septum is pushed towards the right side. So there is less place for the blood to flow, so less flow on the right side. So more flow on the left side, more pressure on the left side on expiration, and less on the right side. On inspiration, there is more flow on the right side, so more pressure on the right side, but the septum is now pushed towards the left side, and less flow on the left side, so less pressure on the left side. So the pressure is discordant. Is that clear?
Okay.
Now, in patient with restrictive cardiomyopathy, there is no restraint. So on inspiration, both LV and RV pressure go down. On expiration, both the LV and RV pressure go up. Okay. So it is concordant in restrictive cardiomyopathy and discordant. So in this patient, it is concordant. So this is restrictive cardiomyopathy. What else? The septal ephraim is very low, less than 5. So at the very least, in constrictive pericarditis, it should be more than 7. What else? You have inspiratory exaggerated gastric flow reversal. So remember, in patient with constrictive pericarditis, at expiration, there is more flow on the left side. Push the septum towards the right side. There is less flow that is available to go to the right side. So they have a back pressure into the hepatic vein. Therefore, you see diastolic reversal in expiration in constrictive pericarditis. Now, in restrictive cardiomyopathy, what happens on inspiration? So in inspiration, there is more flow on the right side of the heart. However, in patient with restrictive cardiomyopathy, remember that the RA pressure is very high. So at inspiration, there is more flow back into the heart, but because the RA pressure is very high, again, you have a backflow in inspiration for restrictive cardiomyopathy compared to constrictive pericarditis. So constrictive pericarditis is expiration, restrictive cardiomyopathy is inspiration. Is that clear? Okay, Celine is so quiet.
Yeah, clear.
Okay. Now, so this is the explanation. So for restrictive cardiomyopathy, inspiration, there is more flow back to the right ventricle. So the weak right ventricle, because they are weak in restrictive cardiomyopathy, can accommodate this, causing a flow reversal in the hepatic vein. In constrictive pericarditis during expiration, due to more flow on the left side and precardial constraint, the septum is pushed towards the right side, and this causes the expiratory diastolic flow reversal. Okay. So this patient that you see just now, that when you look at the CT, you got classified pericardium. When you look at the CAT, got equalization of the diastolic pressure, that suggests you constrictive pericarditis does not have restrictive cardiomyopathy. When you do the biopsy, the patient have cardiac amyloidosis. Okay. Is that okay? Okay. Next one. All right. So this is parasternal long axis view of a patient. Okay. So this is the patient aorta. Okay. Now I wanted you to see this hypodens at the wall of the aorta here, and this hypodens at the wall of the aorta there. Okay. Right. So this is ascending aorta. So this is a short axis view. So this is a short axis view of that aorta. Okay, you can see that hypodens here. Okay. So what is your diagnosis?
Thrombus dissection.
Okay. Right. It's not dissection, so it's almost dissection, but you can see that we have a crescent shaped hypodens around the aorta, but you don't see dissection flag. What is this?
Ulcer.
Not ulcer. Ulcer usually you see some bite. Okay, so what is your differential diagnosis for acute aortic syndrome? So you have dissection, you have penetrating aortic ulcer. What else? What was one more?
Aneurysm.
Intramural hematoma. Remember? So this is intramural hematoma. So in intramural hematoma, what you will see is this. Okay. So what you should see is this. This is your So if let's say this is your aorta, right? So in intramyotal, you will see like the crescent shape like this inside, okay, like that, maybe like this, okay. All right. So you see inside here, you see like this is going to be black. Okay, inside here going to be black. Okay. So this is intramural hematoma, like just like what the patient has. Now, if let's say the patient have dissection, so in dissection, of course, you will see. So this is the aorta, you will see a dissection flap in the middle. Okay, that is actually mobile. So this is intramural hematoma. So Salient, can you tell me what is the etiology of the intramural hematoma? How does intramural hematoma happen?
I don't know.
Okay.
Can I ask something? Sorry. Yeah.
Yes.
This whole thickness look like a
This one.
left ventricle. This whole thing is hematoma lah.
This one thing is in this all three is intramural hematoma. So this is actually aorta. So the aorta is actually dilated, and you can see intramural hematoma here from here to here.
Okay.
Okay.
But we don't see the cusp here, the aortic cusp.
No, we are actually above the aortic cusp.
Oh, okay.
So, Saravanan, what is the pathophysiology of intramural hematoma?
Don't know lah.
Okay, Precious.
There's a break in the media.
Very good. Okay, so there is So what is aortic dissection? So aortic dissection is a sudden tear in intima and medial layer. So there is a tear in intima and medial layer. In fact, if you stand that dissection back to the pathology, you can see intima and medial layer. So intramural hematoma, there is two theories. One theory is that there is a spontaneous rupture of blood in the media, what they call the vasa vasorum of the aortic valve, just sudden rupture of the blood there. And then the blood accumulated slowly. So that is one of the theory. Another theory is people say that like in patient with aortic dissection, the tear is big, but in intramural hematoma, there is only a micro tear in the intima and medial layer. So there is two diagnosis, two theory in terms of how does intramural hematoma happen. How do you manage intramural hematoma? You know, Sarah?
Surgery.
Right. So what they do now is that you manage intramural hematoma the same as you manage dissection. So if you have ascending aorta intramural hematoma, you send for surgery. If you have descending aorta intramural hematoma, that is conservative management.
Medical. Like Stanford A, Stanford B.
Yes, correct. Right, yeah? Right, so this is so some selling point in intramural hematoma. So there are two theories of intramural hematoma. One is spontaneous rupture of vessel vasorum of the wall, and two is micro tear of the intima and media. So intramural hematoma is much commoner in descending aorta. However, if it's occur in ascending aorta, you need to treat it like dissection. So the other acute aortic syndrome are aortic dissection and penetrating aortic ulcer. Okay, there's another case here. So this is case number 15. This is a parasternal long axis view. Okay. So this is left atrium, left ventricle, aorta, and right ventricle. So what do you think is the diagnosis here? Sarah?
Aortic stenosis.
Okay. If you treat the patient for aortic stenosis, what do you think is the etiology of the aortic stenosis?
Degenerative. Is
one of the
calcified.
one of the choices, of course, degenerative. If they say it's degenerative, where most commonly the degenerative mitral stenosis started? In which part of the mitral valve?
Body.
Degenerative will be from the base, right?
Yeah, which part of the mitral valve? Which base? Anterior or posterior first normally?
Oh, posterior.
Posterior first. Okay, if you look at this echocardiogram, okay, where do you think is the worst calcification?
Anterior.
Oh, anterior, right? Where is it? Is it at the leaflet tip? Is it at the
Body.
mid or is it the base? So it's the body of the anterior mitral valve leaflet. Okay.
Yeah.
So do you want to change your differential diagnosis? So if I show you that the classification is the most of the classification is from there to there, do you agree?
Yeah. Yes.
Okay. All right. So where like a classification from there to there is most characteristic of what kind of etiology of mitral stenosis. So the patient, as you can see, also have aortic stenosis. If you were to
Yeah,
do
yeah,
coronary
that's-
angiogram in this patient, the patient will also have ostial blockage of the coronary artery. So what is your diagnosis?
Radiation.
So this is an example of radiation-induced valvular disease. Okay, this is where they always happen from the body of the anterior mitral valve to the aortic annulus. So this is the part. Okay, of course you have to, most of the time it is going to be degenerative. But if the patient have a risk factor, for example, of radiation, so this is very typical of radiation-induced valvular disease. So they normally affect the body and base, but not thick of AMDL. The aortic valve is also typically involved with the coronary arteries. This is the radiation cardiac complication that occur. So the radiation complication occur the latest about 20 to 25, the valve complication. The pericardium complication and the heart complication occurs earlier. Okay, so this also another example of radiation induced for different patient. Okay, so also do you agree this look like radiation induced valvular disease different patient, Sarah?
Yeah, it's more calcified. Yeah.
More calcified in the body and the base rather than the tip of the anterior mitral valve especially. So that's another example of radiation-induced valvular disease. All right, ceiling diagnosis.
Wait. Prolapse.
Nothing wrong with the valve.
Apical ballooning.
Okay, so this is not apical ballooning, right?
No,
So this is not like takut subuh, right? Obviously not.
Autoplus.
No, nothing to do with
Okay.
octopus. This is just very simple. This is not apical cohesion. Just the apical aneurysm, right? It's just LV apical aneurysm, right? I just wanted to show you the difference between aneurysm and pseudoaneurysm. Okay, so this is just apical aneurysm. Now, apical ballooning is usually not as bad as this. This looks like a scar. Apical ballooning, there is no scar yet. So this is just a scar of the apex because of anterior myocardial infarction. Okay.
It's LV aneurysm lah.
Yeah, this is
That's
LV
what they call it.
aneurysm. Okay, so remember the distribution from here to here is can be either LAD or circumflex artery. So looking at this might be for, I think this is supplied by the stirp because you see that it's still okay. From here to there is LAD, from there to apex is LAD. From LAD apex down here is either be LAD or RCA, but this look like LAD. So LAD from here to here, LAD. So this is LV apical aneurysm. Okay, all right. So this is another patient. So this is an echocardiogram of someone, some echocardiogram of apical four-chamber view pre-bypass. So that is left atrium, left ventricle, and right ventricle. Look again. Left ventricle and right ventricle. Left ventricle and right ventricle. Can you see any abnormalities, Precious?
You have a muscular.
Sorry?
Is it a muscular VSD?
So it seems like there is a ventricular septal defect, right? From the left ventricle to right ventricle, correct? So there seems like a flow from the left ventricle to right ventricle. It can be muscular. We don't see really where is the origin. It can also be perimembranous, right? So that is one view. So that is another view. So this is mid-esophageal four-chamber view, okay, of transesophageal echocardiogram. This is left atrium. This is left ventricle. That is right atrium. That is right ventricle. So one more time, left atrium, left ventricle, right atrium, and right ventricle. Okay. So comment, Patience?
I remember. You have a.
So where do you think the flow going to?
You have a flow from the LV going to the right atrium and.
So you can see the flow from the left ventricle to the right ventricle, right? What other flow that you see?
You also have a flow going to the right atrium.
So you also have the flow from the left ventricle to the right atrium. Okay. I show you one more picture. Okay, this is mid-esophageal four-chamber view, and this is the flow from where to where. So this is the right atrium, left atrium, right atrium, right ventricle, right ventricle, right atrium, left atrium. This is the aorta here. Flow is from where to where. This is actually below the aortic root. So the flow is from where to where, see?
Aorta to...
Yep, where? So this is LA, RA, RV. RA.
delta to RA.
So this actually flow from the below the aortic loop. So this is actually the left ventricular outflow tract into the RA. So you have a flow from the left ventricle to RA and RV. Do you agree with me? Saravanan?
Yeah. Yes, yes.
So what's your diagnosis?
Gerbode defect, is it?
So this is example of Gerbode defect. Okay, what is Gerbode defect? So Celine?
Tono.
What is Gerbode defect?
You have
Uh,
PhD and LV going to the right atrium floor.
Very good. Okay, so when you have left ventricle that go to the right atrium, when you have a shunt from the left ventricle to the right atrium, that is called the body defect. Okay.
Can you repeat?
When you have a shunt from the left ventricle to the right atrium, that is called the body defect. Okay. So why do you have? Okay, you have a shunt from the left ventricle to the right atrium. So I just show you ceiling again. Okay. So so this is the one I want to show you. So you can see that you have a flow from the left ventricle, one to the right ventricle, and one from the flow from the left ventricle to the right atrium. So why can you have this? So the reason you can have this is this. Okay. So if you know kind of the heart, the right heart, the tricuspid valve is attached more apically compared to the mitral valve. See, in the membranous region here, you can actually have a place here. If you have a hole, let's say from there to there, if you have a hole there, you can have a flow from the LV to RA. So this is what we call Gerbode defect. G-R-B-O-D-E, Gerbode defect. Okay, so Gerbode defect is shunt from LV to RA. Most commonly, this can either be congenital, but most commonly this happens after cardiac surgery. This Gerbode defect. Is that clear?
After cardiac what?
After cardiac surgery.
Okay.
Why
Okay.
is that?
I'm not sure. Maybe because this area is very near to the way they use their scalpel or something. You know, when you do cardiac surgery, right? A lot of the time you can cause hypertonic VSD. So sometimes it can be in the muscular part. That's quite far. Most of the time you are repairing the valve. You are repairing the perimembranous VSD. Sometimes inadvertently you might poke a hole here and might cause a shunt from left ventricle to right atrium. So this is Gerbode defect.
So anything need to be done to correct that?
Close top, just like you close the VSD effect. If it's small, maybe maybe you don't need, but if it's big, then you have to close it.
Okay.
Is that clear?
Nowadays, they can use percutaneous closure for
I don't know whether they ever close a Gerbode defect with the unplugged.
Can be close.
Can, huh?
No, I think
Okay.
very near the aortic
valve.
cluster.
Yeah,
Alright.
very near the
Right
AV.
behind the valve.
Yeah, very near the AV node as well. Right. Okay, guys, I
Only
think,
membranous.
yep. So I actually plan to do two set, but I think it's too late already. So we will do the next one maybe next week. So thank you for joining me. So this is Gerbode defect. All right. So is there any question?
So far.
All right. So thank you everyone. Sorry, a bit late today. Long number.
Thank you.
Thank you.
Thank you.
Thanks. Bye.
Bye.
Bye bye.